Hello everyone, welcome to JRM Pediatrics. Now this is part 2 of the EEG. Here we are going to do a case-based approach. That is, I'll give you a case scenario and we'll try to identify the EEG from the case. Now see, for EEG we always need to have a history. Like whenever we give a patient a requisition for the EEG, we need to know the background, how the convulsion was there, what's the history behind the disease, what are we thinking of our differential diagnosis. Otherwise, if I hand you over just an EEG and ask you to diagnose, that is not a right process to diagnose a case. Now let's have a look at it. Our first case scenario is a 6-year-old girl who was brought to you by her mother because her teacher observed multiple daily staring episodes in which the child is unresponsive to verbal and tactile clues. These episodes lasted 10 to 15 seconds and occurred 10 to 20 times a day. Immediately after the episode, she resumes normal activity with no recollection of the event. So, we have multiple staring episodes. During the episode, the child does not respond. However, there is no post-ictal drowsiness. Now, let us have a look at the EEG. As you can see here, this is the 1 second aspect I have marked here. Now, let's see how many waves are there. There is a slow wave, spike, and a slow wave, spike and a wave. How many hertz are there? 1, 2, 3. So what did we learn? 3 hertz per second spike and wave pattern is seen in absence seizure. Okay. And what shall we give the patient here? Ethosuximide. Okay. Now let's move on to the next case. A 15-year-old girl presents to the clinic with concerns of morning twitches. These jerky spells occur within a few minutes of awakening. She becomes very tremulous, her arm jolts, and then she drops her toothbrush and comb. She remains conscious during these episodes. Okay. So look at the age and how the seizures take place. Early morning after awakening, her arm jolts and then she drops her toothbrush and comb. What kind of seizure this is? These are myoclonic seizures. Now looking at the age, this can be juvenile myoclonic epilepsy. What did we read? What is the EEG pattern in myoclonic epilepsy? There are periodic complexes of spikes 4 to 6 hertz per second. Okay. Let us have a look at the EEG. Now this is 1 second. Look, there are spikes, multiple spikes with 1, 2, 3, 4. 4 hertz per second. Okay. Let's come to another case. A 7-year-old girl experiences 3 episodes of seizures within a span of 1 month, characterized by paresthesias of the mouth followed by clonic movement of the mouth, face and right arm that occur at night in sleep. This is important, at night. The seizures last for 30 seconds to 1 minute and there is no loss of consciousness. It is a 7-year-old child. Seizures occur at night. There is no loss of consciousness. There is paresthesias of mouth followed by clonic movements of the mouth. What kind of epilepsy this is? This is Rolandic epilepsy or your Beck's. Okay. Now let us look where are the spikes. Here. Okay. The spike and wave pattern. Now where are the spikes present? First, let me zoom it out. Okay. Now as you can see here, C4, P4 and F8, T4. So we have centrotemporal spikes. Okay. Let's go to the next case. A 13-month-old boy is referred for refractory seizures. He is having intermittent episodes of extension of his neck associated with rolling of his eyeballs. These episodes occur 5 to 10 times a day and are not associated with loss of consciousness or postural tone. First, let us have a look at the age. 13-year-old. Referred for refractory seizures. Extension of his neck associated with rolling of eyeballs. Now, even if you don't have this case here, let us have a look at the EEG first. It's a very chaotic pattern. There are multiple spikes, waves, is entirely chaotic. Okay. So what is this? This is infantile spasm or your West syndrome. The treatment is ACTH or prednisolone. And if there is tuberous sclerosis present, we can give vigabatrin. Okay. Now coming to the next case, we have a 8-year-old white girl presenting with intractable seizures since infancy. She was born at term, global developmental delay is present, experiences a multiplicity of seizure types, atypical absence, GTCS, myoclonic drop attacks. There are seizures from the age of infancy. There is GDD in the background. Multiple types of seizures. What is this? This is Lennox-Gastaut. Now, what is the pattern in Lennox-Gastaut? 1 to 2 hertz per second. Okay. As you can see here, 1, 2, 1, 2. See, spike and wave 1 to 2 hertz per second. Okay. Let's come to the next case. A 16-year-old girl is referred for refractory seizures. She was admitted for video EEG monitoring. The results of her neurologic examination are normal. One of the episodes captured during video EEG reveals a gradual onset of facial grimacing followed by forward pelvic thrusting. She appears unresponsive, no urinary incontinence, frothing from mouth, cyanosis or tongue bite is seen. Pupils are normal, normal muscle tone, extensor plantar response. She recollects the episode and has no lethargy or confusion after the episode. So, what is this? See, on video EEG we have seen this facial grimacing followed by forward pelvic thrusting. However, no urinary incontinence, frothing from mouth, cyanosis, no postictal drowsiness, no lethargy, confusion. This is pseudo seizure. Okay, and this is a normal EEG. The age is 16-year-old. In 16-year-old, we can have, if the patient is awake, we'll have alpha activity. If the patient is awake with mental activity, we'll have beta activity. See, there are normal frequency waves pattern, no abnormal spikes or waves. Okay. Here we'll have a few cases quickly, short cases. It's a 4-year-old boy in PICU with bilateral pupil not reacting to light. What is the pattern here? This is a flat EEG. Patient is brain dead. Okay. Here we have a 12-year-old child with deterioration in school performance. First, school performance has deteriorated. Abnormal behavior is present. Father is alcoholic, doesn't believe in allopathy but relies on herbs and traditional medication. Now presents with sudden jerks early morning and clumsiness on walking. There are sudden jerks early morning and clumsiness. So myoclonic type. There is deterioration in school performance, abnormal behavior. Father does not believe in allopathy, so the patient likely or maybe did not take any vaccination. What this can be? SSPE. subacute sclerosing panencephalitis. What is the pattern we'll see? Periodic complexes of generalized slow waves. Now let's see the periodic complexes. See, there's generalized slow waves intermittently. Okay. Coming to the next case, we have a 3-year-old child with altered sensorium and fever for 2 days. CSF study shows 200 cells, all lymphocytic, normal protein, low sugar. Abnormal behavior is present. So there is behavioral abnormality, all lymphocytic cells and the protein is normal. More likely this is viral meningitis. Okay. Now in what viral meningitis there can be low sugar? 2 types. Usually the sugar is normal. Okay. There are 2 types or 2 organisms where in viral meningitis the sugar can be low. They are herpes simplex and mumps. So this is HS, herpes simplex virus encephalitis. What was the EEG pattern here? We used to see PLED, periodic lateralized epileptiform discharges. Let's have a look. Can we see anything? See, here is a spike, spike, a spike, 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 spike. So, we see in frontoparietal 7 and 8 and T4, T6. So, temporal spike is present T4, T6. What about this? If you remember, in the previous video, we had learned F8 and F7 and F8. They are representative of anterior temporal region, but their abbreviations are F because these leads are placed on the frontal bone. Okay. This is a 9-year-old female child with multiple episodes of convulsion for last 6 months, GTCS type. You can see it is entirely spikes, waves, entirely. There's no normal background rhythm much here. So this is generalized seizure. Let's have a look at this. This is the last we have. It's a 3-month-old male child with right-sided focal convulsion of upper and lower limb. On MRI, ischemic region in distribution of right posterior cerebral artery. Now, my purpose here of showing you this EEG is just to show you how even a focal, like an ischemic region of a focal region leading to a focal convulsion can be seen in the EEG. So, this is right-sided focal convulsion. Okay. Let's see where is the spike. Here is a spike. Here is a spike. What are the regions? C4, P4, P4 and O2. Occipital region, posterior cerebral artery. And what does 4 stand for? 4, as we already read, right and even. So 4 stands for right side. Hence, the lesion is on right side. Patient is having right-sided focal convulsion. So this spike is also on the right side. Okay. Thank you. We are done with this video. I hope I was able to make it clear on some EEG patterns. Just the basics at least. Thank you.